welcome to the deep dive. Today we're jumping into a really foundational field in dentistry, prosthodontics.
We are, and we've pulled from some of the core texts out there, think authors like Eckert, Jacob, Zarb, to really focus in on managing edentulous patients.
Right. So our mission here is to distill the absolute must-know facts. This is for you if you're a medical student, a new clinician, or just someone who's really curious about complete dentures and implants.
You want to cover the biology, the materials, the clinical side, all of it.
And I think we have to start with what is, well, a pretty harsh reality.
Right.
We talk about the gold standard of natural teeth.
Yeah, that's the ideal. A healthy, intact dentition.
But with complete dentures, the sources are crystal clear. That standard is it's not on the table.
It's not. It's a huge biological compromise. To really get the scale of it, you have to think about what you lose.
Okay.
A natural tooth is supported by something like 45 square centimeters of periodontal ligament.
45. Wow.
And that's a highly specialized living tissue. It senses force, it absorbs shock, it's dynamic.
So you lose that entire support system. And what replaces it?
A compromised mucosal support mechanism. Basically, you're now resting this hard appliance on soft gum tissue that was never, ever designed to take that kind of load.
That sounds like a physics nightmare for the patient. You go from a suspension system to just resting on the surface.
That's a perfect analogy. And it forces the patient to become what we call an oral athlete.
An oral athlete.
Yeah, they have to actively use their cheek, lip, and tongue muscles just to hold their teeth in place. Every time they chew or speak or even cough.
The dentures are trying to move.
Exactly. They're fighting these displacing forces, lifting, sliding, tilting. It's a constant, exhausting effort.
With all that change and adaptation, it makes sense that the edentulous mouth is, well, it's not a static environment.
Not at all. Two key concepts are always in flux: centric relation, or CR.
That's the ideal relationship between the upper and lower jaw, right?
Right. And the other is vertical dimension of occlusion, the VDO. Think of it as your facial height when your teeth are together. Both of these are profoundly unstable in denture wearers.
Why is that?
Because the foundation, the residual bone ridge, is constantly resorbing. It's shrinking over time.
So as the bone loss happens, the patient's bite changes, their face height changes.
Precisely. And that has huge implications for managing things like temporomandibular disorders or TMDs.
The jaw joint disorders.
Yep. If a patient's dental efficiency is impaired, maybe from tooth loss or ill-fitting dentures that mess with the VDO, it can directly trigger or worsen TMD symptoms.
So before you even think about making a new set of dentures, you have a clinical duty to get that joint condition stable first.
Absolutely. The protocol is clear. You have to use some kind of temporary measure, like a soft liner, to restore the right VDO and get those TMD signs calmed down before you take your final impressions.
You're setting the stage for success.
You have to.
Okay, so moving beyond just the local mechanics, there are systemic factors that can make or break a patient's ability to adapt.
Oh, massively. This isn't just a dental problem. We have to look for things like vesicular erosive conditions, oral lichen planus, for example.
Things that affect the mucosa itself.
Exactly. Or systemic diseases like lupus. Nutrition is another big one. Denture wearers are actually at a higher risk for malnourishment. And then there's salivary dysfunction.
Xerostomia. Dry mouth. Let's dig into that because there's this idea that it's just a normal part of aging.
And that's a myth we really need to bust. Aging itself isn't the primary driver. The real culprits are medications.
For other chronic conditions?
Right. Parasympathetic drugs, digitalis for heart conditions, polycyclic antidepressants. Polypharmacy is the main issue.
And what does that lack of saliva actually do to denture retention? It sounds minor, but I'm guessing it's a huge problem.
It's catastrophic. For retention to work, you need that thin film of saliva to create a seal. The minor palatal glands produce this lubricating mucus saliva that's key. Without it, retention is impossible.
So patients just get sore, can't chew, can't speak properly.
It's a total breakdown of function.
But the sources mention something interesting, a kind of positive feedback loop. The denture itself can help.
It can. It's a great clinical insight. If you provide a really well-fitting, functional, complete denture, the act of using it stimulates the major salivary glands, so you can actually help treat the hyposalivation, not just work around it.
Let's pivot to the darker side of long-term wear, the sequelae. What's the most common problem we see?
Denture stomatitis, hands down. It's incredibly common.
And the cause?
It's usually a mix of things. Trauma from a poor fit, not so great hygiene, the age of the denture, and this is a big one, continuous wear, sleeping in them.
The sources mention the Newton classification for this. Can you walk us through it?
Of course, type I is the mildest, just a localized spot of inflammation.
Okay.
Type 2 is more widespread. You see a generalized redness covering a big patch of the palate.
In type 3.
That's the most severe. It's a combination of the first two, but you also get this granular inflammatory hyperplasia, often down the midline of the palate. And type 3 is very, very prone to a secondary C. albicans infection.
A yeast infection.
Exactly, which makes it much harder to treat.
So given that, what's the absolute non-negotiable hygiene advice you give every single denture patient?
Yeah, it's twofold. First, clean them vigorously with soap and water after every meal. Get the debris off. Second, and this is crucial for anyone with recurrent infections, you do not wear the dentures at night.
Let the tissues breathe.
Let them breathe. The mucosa needs air, and the denture needs to be cleaned and left to air dry or sit in an antimicrobial solution.
All right, that really sets the biological stage.
Yeah.
Let's switch gears to the engineering side of things. Impression materials.
Right. Building these things.
What are the big requirements for an ideal impression material?
The list is demanding. It has to be biocompatible, obviously. Strong enough not to tear on removal. It needs great elastic recovery so it bounces back to its original shape.
And it has to stay that shape, right?
That's critical. Dimensional stability until you can pour the stone cast. And it has to be compatible with that stone.
Okay, let's talk about alginate. It's everywhere, but it's famously unstable. Why does it demand such a rushed workflow?
It's all about time and water. First, it's strain rate dependent. That means you have to remove it from the mouth with a quick, sharp snap to avoid distorting it.
So no slow wiggling.
Never. But the real issue is dimensional instability. It's constantly exchanging water with its environment.
You mean syneresis and imbibition?
Exactly. In simple terms, syneresis is when it loses water and shrinks. Imbibition is when it soaks up water and swells. Both wreck the accuracy.
So what's the clock on it?
It's tight. You rinse it, you disinfect it, and you pour it. Ideally, you want that stone cast separated within 30 to 60 minutes. Any delay guarantees a denture that won't fit.
That's a very narrow window.
Right.
What about the other hydrocolloid agar?
Agar gives you more breathing room. It's heat-based, so you use a special unit to liquefy it, store it, and temper it. The big advantage is a very long working time, maybe 7 to 15 minutes. Great for complex cases.
Let's move to the final product. The denture base itself, usually PMMA. What's the inherent compromise with this material?
The biggest one is water sorption. After we process it, water molecules from saliva work their way into the polymer chains.
And that causes it to do what?
It expands. The base will swell anywhere from 1 to 3%.
1 to 3% doesn't sound like much, but in the mouth?
It's everything. It means the fit changes after the patient gets it. It can alter the bite, cause sore spots. So the mandate is you have to store the finished denture in water before you deliver it. Let that expansion happen in the lab, not in the patient's mouth.
Can we make PMMA stronger? It seems a bit fragile.
We can. You can add a rubber phase to improve its impact strength, make it less brittle. Or, for better long-term fatigue resistance, you can reinforce it with glass or carbon fibers.
And what if a patient is sensitive to the monomer in traditional PMMA?
Then we'd use a light-activated, or VLC, resin. They have less polymerization and shrinkage, which is good. But there are still some concerns about biocompatibility, and their bond to the actual wisdom teeth isn't always as strong.
Okay, before we get to design, a quick word on retention aids. Adhesives and soft liners. What's a big disclaimer here?
This is paramount for young clinicians. Denture adhesives are not a fix for poorly made or poorly fitting prosthesis, ever. They're for psychological security, maybe some temporary help.
Add soft liners?
They're great, but they should be temporary. Long-term use can actually weaken the PMMA base underneath.
All right, let's talk clinical protocols and aesthetics. How do you guide a patient to choose a tooth shade and size without overwhelming them?
The key is a technique called pair comparison. You don't show them a whole shade guide. You show them 2 options at a time and just ask, which one do you like less?
So you eliminate the unwanted choices.
Exactly. You guide them to a decision they feel good about, and you use old photos, maybe even photos of their kids who might have similar teeth to help.
And then the most important step.
Get their signature. The patient needs to sign off on a statement of satisfaction with the waxed try-in before it gets processed into the final denture.
Now for the real secret sauce of maxillary denture retention, the posterior palatal seal, the PPS.
The crown jewel, for sure.
What's it doing mechanically?
It's creating a vacuum. The seal is achieved by putting very slight pressure on the soft, displaceable glandular tissue just in front of the vibrating line in the back of the palate.
And the shape of the palate matters here, right?
Eh,
How's this classifications?
Immensely. A class of soft palate is the most favorable. It's horizontal, giving you a wide, forgiving area for the seal.
And the most difficult?
Class 3. It's a steep, almost vertical drape. Your border extension has to be perfect because if you're off by even a millimeter, the seal will break.
Let's talk about immediate dentures. What are the big wins for the patient?
They are huge. It preserves their psychological well-being. They never have to go without teeth. It also protects the extraction sites and, really importantly, maintains the tongue's position.
It prevents the tongue from spreading out into the new space.
Right, and it just makes the whole adaptation process much more gradual.
And this involves a step called cast surgery. What's that?
It's where we trim the stone model to estimate what the bone will look like after the extractions. We use a clear surgical template during the actual surgery to check for pressure spots, what we call blanching.
So if you see the tissue turn white, you know you need to remove a bit more bone there.
Exactly, to get a nice passive fit.
Yeah.
But it's not a one-and-done procedure.
Right. You have to warn the patient about resorption.
You must. That bone is going to change a lot in the first 3 to 6 months, and they will absolutely need a reline or a rebase to keep the denture fitting well.
Okay, let's move to speech. How can we use sounds to diagnose problems with tooth position?
It's a great diagnostic tool. Take the linguodental sounds like briff.
That's your that.
Right. Ask a patient to make that sound. If you can't see about 3 millimeters of their tongue tip peeking between the teeth, it probably means the front teeth are set too far forward.
What about sibilance? The S and Z sounds, a lisp.
A faulty S sound often means the tongue is cramped. You might need to add a little thickness to the center of the palate to create more space, or check that the lower denture flange isn't in the way.
Finally, let's touch on advanced cases, implants, especially in compromised patients, like someone who's had radiation therapy.
A really important topic. The big contraindications are smoking, which just tanks success rates, and previous radiation. Irradiation is a relative contraindication. Success rates are expected to be about 10% lower.
Is there anything we can do to improve the odds in irradiated bone?
Yes. Hyperbaric oxygen therapy, or HBO, is recommended. Studies show it improves success by increasing the blood supply to the bone, which is critical for healing.
What about materials? Is titanium still king?
Commercially, pure titanium is still the gold standard for biocompatibility. Zirconia is an option, but there are still some long-term questions about its brittleness compared to metal implants.
And when things go wrong?
Screw loosening is the most common complication, and it's usually an easy fix. Implant fracture is very rare. The screws are designed to be the weak link. They act like a fuse and break first.
I see.
If an implant does fracture, it's a surgical removal, usually with a special drill called a trephine.
So this has been a real journey, from the fundamental biological compromise of losing your teeth, through the precision of material science, and into the fine details of clinical work.
I think the biggest takeaway is this. Prosthodontic treatment isn't a cure, it's palliative. You are managing an ongoing biological process. The ridge will resorb, the bite will change, and you have to be there to monitor and adapt with the patient for the rest of their life.
A powerful point. And with that, here's a final review exercise for you to think about. We talked about the fragile mucosal support system and the challenges of dry mouth.
Right.
So, can you explain the critical differences in how alginate impression material and heat-cured PMMA denture resin handle dimensional stability? And why do those differences demand completely opposite handling protocols?
Think about the water. Is it being lost or is it being absorbed? And what does that mean for the final fit of the denture?
An excellent question to chew on. That's all the time we have for this deep dive. Go forth and remember how much material science really dictates prosthetic success.